Good morning, everyone.
Good morning, everyone. Thank you. So, Michelle, how are you today?
Oh, good. Had a good sleep, and you?
Oh, me too. I have a good high dose of melatonin. Thank you.
Oh, good. And
All right.
your 3 grams of vitamin C.
Yeah.
Okay.
More than that.
More
Okay,
than
Michelle.
that. Okay.
All right. We are at the second day of our conference, Longevity, Hope for Change. So, will be the last day, actually, Sunday,
Yes.
7th July, 2019. All right. I guess all of us are ready. Before we call upon Prof for presenting the first talk, we would like to invite. Hold on. Yeah, all right. Yes, I can see you. Thank you. Again, we would like to invite Dr. Mazia, Organizing Chairman, Longevity KL 2019, to welcome her welcome notes. Please welcome Dr. Mazia.
Yang berhormat Dr. Azman, Yang hormat Datuk Dr. Shukri, President of Perdim, Dr. Homer, Co-Organizing Chairman for this Longevity KL 2019, Honorable Speakers, distinguished guests, delegates, media, ladies and gentlemen, Assalamualaikum warahmatullahi wabarakatuh, and very good morning. How are you today?
Good, great.
After such a long day, yeah? Exhausted? Still excited? How was the food last night?
Good and spicy.
So,
Yeah.
But first of all, I would like to apologize for the shortcomings yesterday and last night. Yesterday, the program was so packed, even I couldn't take it, but I'm very, very sorry because our intention is actually to impart as much knowledge as possible. And last night, there was a bit of hiccups at the registration for the dinner. Apologize for that. But having said all those negative things, one good thing I want to share with you, the Federal Territories Minister has agreed to make Kuala Lumpur and Putrajaya as the longevity city of Malaysia. Soon, he said maybe we can be better than the Okinawa. Luckily, Dr. Aso is not here. Okay, what do you think of yesterday's lectures? All the lectures that you listened, you had yesterday. Was it good and eye-opening? Yes. That's why I really seek your help, your cooperation to pass this message across to those who are out there, who are still debating and accusing us, the practitioners of integrative medicine and the holistic medicine as the deviated teaching. For them, whatever they have learned in the medical school, the conventional, so-called mainstream, that is the right teaching. You know how long what sort of problems I had to face just to get this CPD approved for this conference. It took me almost 3 months just to get the CPD because those people who are in the approval committee for the clinic CPD points, they are all, most of them are surgeon, mainstream practitioners, and none of them are integrative or holistic medicine practitioner. Or for that matter, functional medicine practitioner. So for them, they thought that, whatever I presented, it is all like, the deviated teaching. And so I had to go through, I had to ask help from Prof. Amin, Dato' Nora, Prof. Fred, to give me all because to them, whatever the list, the topic listed, not a single topic to them should be given the CPD point, should be approved. So I had to go through, presented to them all the scientific evidence. When did I get the approval? On the Hari Raya Eve. You just imagine, everyone, they are going to celebrate Hari Raya, but I was there sitting just to get everything done. But thank God, we got 34 points. Okay, sorry for the international speakers and delegates. What I'm sharing is actually our domestic problem. I'm not sure whether out there you all facing the same thing. And for that matter, actually, I extended this invitation to all the other medical fields, including dentistry and all that. I approached, actually KKM was supposed to send a number of delegates to join this, but at the last minute, they told me from the dental department, they said, "Oh, this conference has got nothing to do with dentistry." Just imagine yesterday what Dr. Lemos has presented to us. It was so, it's an eye-opening. And then I asked them, for that matter, I'm still seeing you all doing that filling with amalgam. Don't you think that is dangerous? You know what they say? Oh, actually, it is in our pipeline. We want to go amalgam-free by year 2022. Then I told them, oh, I hope I'm still alive to see that this thing, come true. Then from the other division of KKM, suddenly they just said, oh, this not important to them. Just imagine if our top level thinking is that way, what more just the ordinary GP. So I hope all of us today go out and tell them whatever they have learned in medical school 20 years, 30 years ago is not necessarily still applicable now. Those days, when I was a medical student, the first time they discovered H. pylori, everybody's so excited. But we can't be cuddling, that H. pylori until now. Everything has changed, but they don't want to change. Even my textbook, when my my children, they are doing medicine, they told me, Mom, your textbook, a lot of things they said, oh, it has yet to be found. That means there's no evidences at that time, because I think I graduated about 30 years ago. So ladies and gentlemen, please guide our fellow doctors out there. Come learn. Seeking knowledge is actually paramount to our practice. It is sinful if we cannot give the best to our patient. I had, just to share with you quickly, before my Madam Linda chased me down, I had a patient who came to me last 2 months with unresolved fever, swelling of the jaw, but she was just been discharged from the hospital. She was admitted for almost a week, But it seems they told her, sorry ma'am, we couldn't find any underlying cause for this. So she was discharged with just the oral antibiotics and paracetamol. So she came to me, I told her, I said, I think this is something to do with root canal. I'm not a dentist, but I can refer you to to one of the biological dentists in KL. But she suddenly looked at me one kind, Doc, I've been in that hospital for almost a week. Don't tell me that they don't know about this. I said, sorry, I can't comment on that, but let me refer you. I spoke to my friend, it was true enough. So I think it's sinful. We miss the simple diagnosis. After that, she recovered. Now, she start to get all her friends to go to this dentist, for those who with amalgam filling and all that. You see, if we don't go and seek knowledge, how do we want to upgrade ourselves? Okay, I will not take any longer. I wish you all the best, happy learning, good luck. Thank you.
Thank you. Thank you, Dr. Mazia, for venting out. We hear you. All right, a little housekeeping announcement. Actually, we're having a feedback form have been distributed, as I understand. Please return the feedback form at the end of today's session. The second one, certificate also can be collected at the registration counter. And those who have not paid for the books, please do so. And also, we're having a lucky draw, Michelle.
Yes.
Maybe we'll do it after the morning break, just before Datuk Nora's lectures. We actually have more than 10 lucky draws to be given out. We're supposed to do it yesterday. So, all right, so we do it today then. Okay? All right?
Sounds good. I hope we're part of the lucky draw.
Okay. Over to you, Michelle.
Okay. For our first speaker this morning, he does not really need more introduction because we have not only heard from him twice already. We know, though, that he loves to teach, and that's precisely why we have him here. Just a short one. He is the director of the Department of Applied Cellular Medicine, member Delphi group concerning embryonic stem cells for human use, and established by the German Ministry of Health and German Ministry of Education and Research. Our guest professor, Faculty of Medicine at UITM Sungai Buloh, here to teach us more this morning, Professor Dr. Fred Fandrich.
Thank you very much. Good morning, dear colleagues. Today I'm much more relaxed because the first 20 minutes are already gone, so no one really can blame me if I run out of time. I want to make a statement. I'm really very grateful to Ibu Masia Yaakob that she has set up this fantastic forum for you. Because, no, really, I'm a faculty member, and I have to tell you a little bit about my own CV curriculum. I was chief head of the surgical department in Kiel at my university, and at one point in my life, I had what you would call a near-death experience, and I really could see that there's something totally different, another dimension in this world, in this universe. So, and shortly after this experience, the administration, the university, offered me my own department for cellular medicine. And that was quite a tough decision for me to make because, can you imagine, being the chief surgeon of a university, you are quite a powerful man. And taking over a department for cellular medicine, you are a nobody, really. You step down from 40 consultant doctors to one. But I took this decision because I felt there is something else than conventional medicine. After having practiced surgery for more than 25 years and doing all these rounds with oncologists and all these other people who stick to conventional medicine, I realized, well, there is, of course, some some importance in doing that, but it doesn't really help in a lot of cases. And we have to take a much more holistic view on how to treat patients. And what I actually want to give you as arguments in favor of what you are doing is, if you look in the universe, there is 100% of the energy. And this energy comprises 4 types of energies which we can access with our physical knowledge and means. This is strong forces, weak forces, electromagnetic forces, and gravitational forces. These are the 4 energies which we can describe with our current physical knowledge. But astrophysics tells us that there is something else. There is dark matter and there is dark energy. So now I'm asking you, how much of the energy in percentage comprises those 4 which we can actually access? This is only 5%. 95% of all energy in this universe is dark matter and dark energy. So, if we can only access and measure 5% of the energy which is around us, we are working in a huge black box anyway. And anyone who's telling you your holistic medicine is not evidence-proved, you can tell, well, the whole knowledge we have is not evidence-proved because it comprises only 5%, right? So having said that, I want to proceed. Can I get my presentation, please? And to indulge into science. And the one who has realized that is my friend Albert Einstein. I have to cite him again. Logic will get you from A to B. Imagination will take you everywhere. So it takes more than just hanging on to what has been published and said. Create your own ideas, be imaginative, be creative, and that's what's important. Now, when I want to talk about chronic disease and immunotherapy and working with cells, which is a specific new field in medicine, I want to give you a little bit an introduction how I came across this topic of cellular medicine, being a surgeon. Well, most of my time I did transplants, and I was always more or less frustrated when I saw you do a kidney transplant and then you give these cyclosporine inhibitors, tacrolimus, and you kill the kidney with the toxicity of the immunosuppressants you give. So what you want to do is actually to induce a state of tolerance that you don't need these immunosuppressive drugs. And the first person, actually, he's considered the father of transplantation because he did fundamental work in the field of immune tolerance. That was Sir Peter Medawar from England, and he got the Nobel Prize for his Nature publication, Acquired Immune Tolerance, in 1960. And what he actually showed was, if you take splenocytes from a genetic different mouse and transplanted it in utero, into an embryo, and then this embryo is born and grows up, and later in life you can transplant a skin transplant from this genetic different donor on this preconditioned mouse, and it will accept the skin. So what Medawar was actually showing is that tolerance is not something which is inscribed firmly, which is rigid. It can be modulated by the immune system. And that's the intriguing thing. You can modulate your immune system to certain antigens. And then we did our own approach. We turned around the approach from Medawar. We took embryonic stem cells from the inner blastocyst of a mouse, transplanted those into the portal vein of a genetic different mouse, and 7 days later we transplanted heterotopically a heart into the abdomen of the preconditioned animal. This is published in this Nature publication in 2002, and the result very quickly. So you take the cells from embryonic blastocysts from mouse A and inject into mouse B, and then 7 days later you do the heterotopic heart transplant, and as a control we transplanted hearts from a third-party genetic different from this mouse into the same recipient. And what we saw was actually if you precondition these Lewis, actually it was rats, these Lewis rats with the embryonic stem cells, then in comparison to untreated or third-party grafts, we found long-term acceptance in about 80% of the cases. Now, what is not in this publication is that in about 10 to 15% of these transplants of the transfer of embryonic stem cells into the portal liver, we found teratoma and carcinomas in the liver of the recipient animals. And you could never predict when this was going to happen. So for me, clinically, it was a great success to have tolerance, but I wouldn't dare to transplant embryonic stem cells if I would induce a cancer in my patient. So what I did was we looked by haplotype identification. We looked for cells which derived later on from these embryonic stem cells. And we found that 90% and more of all the cells which were haplotype identical with the donor strain were monocytes. Monocytes are white blood cells, and they're very versatile. They're very flexible in being programmed in one or the other direction. So we focused on these monocytes and identified a population of anti-inflammatory, tolerizing regulatory monocytes, which we then isolated and repeated the experiments. So the next one here is we did a very, very vigorous transplant model in skin transplant, transplanting skin from DA rats on Lewis rats, which is the most vigorous model you can have in rodents. And you see, here is the syngeneic control. If you put a Lewis graft from a Lewis rat on a Lewis rat, this is like identical twins. You suppose it wouldn't be rejected, and it was not rejected. If you take the allogenic DA skin, it heals in without rejection, whereas the genetic third-party control was rejected. And that proved that actually these tolerizing monocytes, if you pre-treat this animal with monocytes from DA rats and then put on a DA skin graft, it's not rejected. So, having found this and demonstrated this, we went one step ahead and we did preclinical experiments in pigs where we transplanted lungs. Remember, I'm a surgeon. So here in these pigs, we transplanted the left lung, and we had the right own lung as control. And this was the immunosuppressive regimen. We gave these regulatory macrophages in one group, and the control group only had the immunosuppressive drugs. And what you see is if you precondition the animals with the regulatory macrophages from the donor animal, then you have a long-term survival in lung transplants, which is very, very critical because lungs are directly exposed to the external environment and the rejection rate is quite high. So here's just the X-rays where you see this is an untreated animal. After 41 days, you have this clear lack of transparency in the lung lobe, which indicates rejection which was then controlled by bronchoscopy, which you did not find in the tolerized grafts. So having found that, we got in parallel, you see the whole science started in 2001 and it took us to 2011 until we got a manufacturer license from the government to do more clinical work. But in the meantime, we were allowed to do 2 trials, which I'll show you some results. Now, what I want to make clear to you, if you work with cellular medicine and you have a certain cellular product, it is important not to harm your patient. You really have to show that the cells are working, that you have a sort of dose-response relationship. For clinical utility, it's favorable if the cells are easily obtained without being too invasive, and it must be affordable to the patient. Now, you have to show consistent quality of your product, consistent quantities, and a consistent biological effect. And of course, you have to describe the side effect profiles and risk and complications which are associated with this treatment. And having done all that, we were allowed to do clinical trials. And these are all the publications and awards which we got for this development. So there is a lot of scientific work behind it, and it was a lot of fun. Now, that's my introduction. I want to show you now in which context you can actually use cells to treat various kinds of diseases. And in order to give you more details, you need to understand a little bit about the biology and the classification of monocytes. Monocytes are white blood cells. They comprise about 8 to 12% of the white blood cells, and they can be programmed basically in two different directions. Once monocytes infiltrate the tissue, they are actually so-called resting macrophages. And those resting macrophages, they can turn into classical activated inflammatory macrophages or in deactivated anti-inflammatory macrophages. These ones, the inflammatory, are called M1 polarized, and these ones are the M2 polarized macrophages. You need inflammatory macrophages to kill virus, to kill certain bacteria, and so on. You need M2 to balance over immune activation. And for instance, if you treat cancer patients and you produce dendritic cells, the dendritic cells come from classically activated macrophages because they have to trigger T cell responses and activate cytotoxic T cells to kill tumor cells. The totally different is if you treat autoimmune disease. In autoimmune disease, you have activated autoaggressive T cells which attack your own tissue. And in that context, you need M2 anti-inflammatory macrophages which downregulate the T cell response. And I will give you examples for that. And then we have a third type of macrophage. We call them programmable monocytes. And they are produced a little bit different. And they are also anti-inflammatory, but they have an extreme pluripotent potential to regenerate tissues. And I will also give you some examples for that, how to use those cells. Well, again, in chronic disease, and that's my topic, what is the common denominator of chronic diseases is that you have a misbalance between M1 inflammatory and M2 anti-inflammatory macrophages. For instance, in type 2 diabetes, I'll show you in a second, you have an abundance of inflammatory macrophages which inflame the fat tissue, produce inflammation, and cause insulin resistance. And the same is true for atherosclerotic disease, where you have inflammatory macrophages in the endothelium, which cause atherosclerotic plaques. And the same is true for type 1 diabetes, basically for any chronic disease where you have ongoing macrophage T-cell activation producing inflammatory cytokines, and you have a lack of immune regulation. This is what you have to understand. Now here's an example for how insulin resistance is produced. If you overeat and you get obese, you have a hypertrophic fat tissue. And apparently what happens is in lean persons, if you look into the infiltrating immune cells into the adipose tissue, you have so-called M2 anti-inflammatory macrophages which produce IL-10. IL-10 is a suppressor cytokine which regulates and downregulates the immune response. The more you get fat and accumulate fat tissue, the more you have the infiltration with M1 inflammatory macrophages, which produce TNF-alpha, IL-6, MCP1, and other IL-23 IL-1 beta, all these inflammatory cytokines, and these cytokines create an environment of inflammation, and the inflammation will then cause insulin resistance in insulin-sensitive tissues like muscle and liver tissue. And that's the mechanism. And this applies for basically any type of chronic, ongoing inflammation in any organ. Okay, so how do we produce these monocytes? You do an isolation of CD14 positive monocytes from the peripheral blood, and then you add a growth factor, macrophage colony stimulating factor, MCSF, over 5 days, and on day 5 you pulse these monocytes with interferon gamma, and then on day 6 you have a reprogrammed monocyte, which we call regulatory macrophage. And they have 2 properties. These macrophages can actively eliminate alloreactive effector lymphocytes, which means if you have autoaggressive T cells which attack, like in a setting of an autoimmune disease, which attack your own tissue, these macrophages are able to eliminate those. And at the same time, they will induce regulatory T cells, memory T cells, which keep the memory and balance the immune system. Those are the 2 important properties of these regulatory macrophages. And don't get confused. Initially, when we started this work, we called, if we use these MRECs in an autoimmune setting, we call them self-tolerance inducing cells, STIC. So that's the same cell as the MREC. And here's a picture of the morphology of M1 cells. That's how they look like. They have little dendritic extrusions, whereas here are other M2 types which have been described. But our MRECs, they have a very typical design. They look like fried eggs with a very skin cytoplasm rim. And that's a very typical picture, and you actually, by looking in the microscope, you can already detect and say these are the cells we need. We did a lot of phenotypic comparison. What are the markers expressed on MRECs and all these different other types of macrophages, and we get a very specific profile of markers expressed, which give us the possibility at the end of our manufacturing process to look for certain markers which must be expressed on these cells. And 2 markers which should not be expressed is toll-like receptor 2 and toll-like receptor 4. They are downregulated because that indicates that these cells cannot be triggered by DAMP or PAMP receptors to become inflammatory. So, having said all that, I go into the clinic. The ethical committee and the government wanted us to show what's actually happening in a patient when you inject these MRECs into a patient intravenously. So what we did, we labeled these MRECs with the radioisotope indium-111, and then we injected them intravenously into a patient. Now, this patient was a potential recipient of a kidney who got the kidney from the mother, and the mother donated for the daughter. So we took the MRECs from the mother and injected them into the daughter, and you see after 5 minutes, these cells, they are hanging around in the lungs, and after 2.5 hours, if you do scintigraphy, you can see that they are now in the liver and they start going into the spleen. This is after 4.5 hours, and over time, this is after 22 hours, the lung fields are cleared again, and you have predominantly these cells in the liver, in the spleen, some lymph nodes, and after 30 hours and 36 hours, we found also quite a lot of them in the bone marrow. And remember, this is allogenic. This is from the mother on the daughter, and the daughter was not immunosuppressed. So we can actually show here that there is no rejection of these monocytes because you do not see any activity, radioactivity over the bladder or the urinary tract. If the cells had been rejected, they had released the isotope which had been cleared by the urine. And since you do not find any activity over the bladder and urinary tract, this is evidence that the cells are intact and not destroyed. Now, these are the two studies where we actually could show that we were able to substantially reduce the amount of immunosuppression in these patients. And we then entered a trial with the European framework where you get a lot of money. It was a multi-center study where we monitored tolerance, and we were allowed to participate with our patients. And so what we do, actually, we do leukapheresis. We isolate the white blood cells, then we isolate the monocytes by magnetic bead separation from the white blood cells. We culture them with MCSF, interferon gamma, and then we re-injected these cells into the recipient. And the same is the same protocol if you do it for autoimmune disease. And here is two patients, and one of the tolerance markers which have been described by others are an increase of absolute B cell numbers in patients who are tolerant to their transplant. And you see in both patients, this was the case where the mother donated for the daughter. This is a living, non-related transplant where you had six HLA mismatches between the donor and the recipient. And these people normally vigorously reject the graft. And you see, although this guy increased his B cells. And this is work from Professor Robert Leckler from Guy's Hospital in London. He had access to our patient blood and samples. And what Robert was doing, actually, he compared the gene signature of patients with chronic rejection, you see here, with under prednisolone or calcineurin inhibitors. And then he had 28 patients who had never rejected the kidney, even they had dropped the full immunosuppressive drugs. And this is apparently the gene signature. You see all the red spots of genes being upregulated in tolerant patients. So we compared this gene signature with our patients, and here's the mother-to-daughter patient. You see, she very, very quickly developed the expression pattern of tolerant patients, whereas our other patient with the 6 mismatches, he did not in the beginning. But if you look over time, this is the blue line. He started down there, and then he upregulated tolerance expression profiles. So I give you another publication here. This we recently published last year in Nature Communications, and we show in this publication that after 8 years after transplantation, this patient with the 6 HLA mismatches, who was just on a very, very low dose of tacrolimus, below trough levels, you can't even measure it in the blood, he did never reject, and we could find donor-specific regulatory T cells in his blood which from rejection. So that was evidence that actually the preconditioning with these macrophages can induce a state of tolerance where you downregulate the immune response against the graft. Okay, so much to transplantation. Now I will proceed with something else. Our thinking was, if this works in an allogeneic setting and you can induce tolerance to organs, it should also work in a setting where you have autoimmune disease. And we treated a lot of different indications, rheumatoid arthritis. The cells work extremely well in patients with any type of vasculitis. For instance, lupus, sclerodermia, Sjogren's syndrome. These are extremely good indications because the vessels are affected, and these macrophages have a preponderance to go into the vessels and to regulate inside the arterial wall. Now here we started with a model of inflammatory bowel disease where you create this with injecting activated T cells, which will infiltrate the mucosa and cause inflammation in the bowel mucosa. And after 6 weeks, having induced this colitis in these animals, we injected 5 million of Mbrex, and controls just received saline. And what we found was that the treated animals, they went on and were gaining weight, whereas the untreated were losing weight and dying. And 2 pathologists, which were actually blinded to the animal experiments, they just explored and assessed the histological score, and you see there's a significant difference of inflammation of colitis in animals, treated or untreated animals. And histologically, you see, if you look at the animals 3 weeks after the injection of the cells, this is an untreated animal. You see the huge infiltration and inflammation going on, destruction of the villi and the morphology in the bowel, whereas if you give these immune regulatory cells, you can restore the integrity and get rid of these inflammatory cells. There are little clusters still left after 3 weeks, but they recover completely. So that is published in Journal of Immunology. Then next, we went and looked how does it work in type 1 diabetes. And in type 1 diabetes, you must know, you see here an islet and infiltration of the islet with autoaggressive T cells. And if 75% of the islets are destroyed, then patients become symptomatic. So you must know, once a patient starts to need insulin, more than 75% of the islets are already destroyed. That's a bit a problem because you have to reverse this process and to restore islet formation. Anyway, what we did, I had this little boy, 12-year-old. He had first manifestation of type 1 diabetes in May 2009. And we were able to detect all these insulin-specific antibodies destroying the islets. And then he was started on insulin. Here's the dosing. And we got ethical approval to perform this cellular transplant. We procured the cells from the father because we didn't want the boy to undergo leukapheresis. And then we finally injected him in July. And this is what happened. We also performed a mixed meal tolerance test and measured glucose and C-peptide levels in the boy 1 month after the injection of the cells. So here is the result of glucose profile and C-peptide profile after the mixed meal tolerance. You see that he's climbing up to above 200, and he cannot produce a lot of C-peptide anymore. And this, at this point, this was before we injected the Mbrex. He had an insulin need of 0.45 units per kilogram per 24 hours. And with this treatment, his HbA1c was 7.1%. Now, then we injected and we measured 1 month later. We repeated the glucose meal mix tolerance test, and you see 1 month after injecting the cells how he had improved his glucose profile and even had a better C-peptide response. Even his insulin need was less than half than before, and he had a much better HbA1c. So the injection of these cells had improved his metabolism quite significantly. So I want to summarize this first. I think that these immune tolerant cells, they describe a novel state of activation and are able to suppress activated autoaggressive T cells. They delete autoaggressive T cells, and they enrich at the same time regulatory T cells, which is important to sustain the balance and the homeostasis of regulation. they do migrate to the peripheral lymph nodes where they counterattack M1 inflammatory macrophages. And we have actually documented the therapeutic potential in preclinical models and in clinical. And before I give you more other clinical evidence, what they can do, I just want to quickly address two important things. What is involved in chronic disease. I think that the common outcome of any of these critical triggers of chronic disease, like infections, dysbiosis, radicals, advanced glycated end products, cancer, all of them, they produce acidity. And I want to stress, I did last night, the importance of the microbiome. I want to give you some more information of what is advanced glycated end products and how to regulate this acidity in the context of cellular medicine. Now, what you really have to remember, any ongoing inflammation in the body by releasing prostaglandins, cytokines, and so on, will cause inflammation and will cause acidity in the tissue. The pH drops, so you have an acid tissue microenvironment. Any acidity in the tissue, which you are familiar with, causes the activation of NOTC receptors. These are receptors which respond to acidity and cause pain. And it will weaken your immunity, and it will alter the metabolism, loss of mitochondrial activity, and this is important, we are here in a congress for longevity. In a acid environment, your stem cells are paralyzed. That's what you have to really remember. If you inject any type of stem cell into an inflamed knee joint for knee pain, they will work for a few days and then they will just be gone. So it can't last. So you have to condition the environment before you inject your stem cells. That's what I'm saying. Now, we did that test. You take mesenchymal stem cells and you culture them and they produce growth factors, and you lower the pH in the culture, easy to do, and you will see that the amount of growth factors is significantly reduced the more you reduce the pH. This is true also for VEGF, and this is true for PDGF. Same pattern. In an acid environment, stem cells are paralyzed. Just remember that. So you have this picture seen last night. If you have a dysbiosis and leaky gut, then macrophages and other immune cells will be activated and cause chronic inflammation. So everyone with a leaky gut has an ongoing chronic inflammation. And as long as the leaky gut is not closed, you can't change it. And that's a critical factor to cause chronic disease. And one other thing is the formation of advanced glycated end products. I want to give you a little bit more on that. So it has been shown that the formation, and I will tell you what are advanced glycated end products. I will tell you in a second. It has been published that glycation end products are known to be mainly associated with aging, neurodegenerative disorders, diabetes, atherosclerosis, renal failure, and a lot of other diseases. So what are they? If a glucose carbonyl group is the amine group of protein and they stick together, you have the formation of an advanced glycation end product. This is the preform intermediate, and if this reaction stabilizes and bridges, then you have a irreversible advanced glycation end product. And the same, so you must know, here is the protein, and then you have these sugar groups binding to the amines, and what happens actually, the three-dimensional configuration of your protein is disturbed. And if the protein doesn't contain or doesn't sustain its three-dimensional configuration, it cannot bind properly to its receptor anymore. And if it cannot bind to its receptor, it's useless. it will float around in the blood and then integrate into tissues, infiltrate, and be deposited. And a lot of people with fibromyalgia and tendon pain and a lot of things, it's just the amount of AGEs which are deposited and causing the problem, inflammatory proteins. And the same is true in Alzheimer's degeneration and so on, in all these diseases. So you have an exogenous source by pollutants and by especially the nutrition you eat, which causes ages, and you have metabolism inside the body, especially inflammatory events which catalyze the formation of ages, and it's like a vicious circle, produce oxidative stress, produce more inflammation, produce more AGEs. And this is what you have to look at. Everything I like to eat has high amounts of AGEs. That's a problem. For instance, I give you one example. If you take 100 grams of potato and you boil them and then you eat them, then you have 17 units of AGEs. If you take the same amount of French fries, 100 grams, and you eat them, then you gain 1,522 AGEs. The same is true with fried beef and so on. So it depends, of course, on what we eat, to which extent we cause inflammation in our body. And all these diseases have been published to be related to the formation of AGEs. It's huge. It's basically the eye, it's the brain, it's everything in our body. Now, one example. Here you have arterial lumen and the blood is flowing here. And what happens is LDL particles are getting access to the intima, interior wall of the artery. And inside the intima, if you have abundance of oxidative stress and free radicals, they are oxidized. And then oxidized LDL can bind to the CD36 receptor on macrophages, and these are inflammatory M1 macrophages. So once they bind and internalize these oxidized LDL, they turn into foam cells, and these are the precursor cells to form atherogenic plaques. So you see the combination of metabolism, oxidized LDL, immune activation, and disease. And what we do actually with our anti-inflammatory macrophages, we can eliminate this process of foam forming and we can kick out these inflammatory macrophages. And we have seen tremendous improvement in atherosclerotic plaques if you inject these anti-inflammatory macrophages. I will show you some pictures later. So it has also been shown, this is a huge trial from the Mayo Clinic where they tested more than 1,000 women and measured the level of AGEs in these women. And what you see actually, those women with the highest quartile of AGEs in their blood, the highest 25%, they had a significant higher risk of dying from cardiovascular disease. Okay. So much for that. Now I want to give you some examples of how to use regenerative monocytes. The regenerative monocytes are procured in the same way as the regulatory monocytes. However, we do not stimulate with interferon gamma. We add interleukin-3. And I don't want to go in all these details. We have a lot of publications on that, why we use the IL-3 and so on. But they have really a great potential to regenerate, especially ischemic problems, because they produce angiogenic factors which create new little capillaries, and in any hypoxic ischemic tissue, stroke, cardiovascular disease, ischemic limb disease, they are perfectly to use, and that's what I want to demonstrate. So I had a patient, he had a diabetic vasculopathy, 67 years old. He was referred to my department for amputation of the left lower limb. But the poor guy already had undergone previously a right lower limb amputation. So he refused to have his second leg be amputated. So, but the guy was already septic and he was about to die. So I said, well, the last hope we can have is to inject these cells to restore the perfusion. Now, we actually tried it and tried to take his own monocytes, but he was so septic that we could not reprogram. So we had to use monocytes from a healthy donor. And here are publications you can read up which give you more information on these monocytes. And so this was the HLA typing. You see there was a mismatch between the patient and the donor, blood group compatible, which is not necessary. And then we injected 8 times 10 to the 8 million cells. And here you see, this is after surgical debridement of the necrotic tissue. You see I am injecting intramuscularly the cells around this ulcer. And this is after 2 weeks. You don't see much, but clinically, very interesting. After 2 weeks, the patient did not need any painkillers anymore. His ischemic pain was gone. This is after 2 weeks. This is after 8 weeks. The upper part is closing. You see here, 13 weeks. And he got only 1 injection. We repeated the angiogram, and the radiologist identified the collaterals which had been created in the tissue, which perfused the distal part of the leg now. And this is after 24 weeks. The wound is basically closed. And he never had problems again. This is another patient who was referred for foot amputation. You see the edema, the necrotic toe, lack of perfusion, arterial occlusive disease. After injection of the cells, 3 weeks later, the edema is gone, the inflammation is gone, and we just did a minor amputation of the toe. Another example of a diabetic patient with a diabetic ulcer, hospitalized for months without success. So we injected the cells. We do thermography to see the improvement of perfusion or sonography. And this is after 6 months. The wound has closed. The patient can walk, no ischemic pain, and we rescued his leg. And the last case, a patient from Malaysia, actually, who suffered from diabetes and came presented with this big. There was basically, you could see the bone beneath, and it was very hard to inject cells, so I couldn't inject here, so I injected him around the dorsal artery here. And you see over time, it completely recovers the skin, and the wound has closed, and the patient was happy, he could walk, had no pain, and no amputation. So I think this is a very rewarding thing to do. You inject these cells, and you create a new angiographic vessels which perfuse the tissue with oxygen, and they can heal. Now, these are infusions which we simultaneously use. I told you that the DCA we give in order to reverse the lactate formation in the cells, the metabolism, and the relief we give in order to balance the tissue pH. The relief will normalize the tissue pH, and then you can inject the cells, and then they are not killed by the acidity. And then we give Mito, our compound, which boosts the mitochondrial activity, and those 3 are the basic ones which are very important. Last not least, give me 5 more minutes. I want to give you just some ideas on how to use cells to treat cancer. Well, in cancer, I told you, you have to not to use monocytes which downregulate the immunity. You have to activate the immune system. And that's what we do with dendritic cells. And dendritic cells are produced with different cytokines. You use GM-CSF as a growth factor, and IL-4 and prostaglandins and TNF. And then what is important, you need to inform your immune system which cell to attack. So you have to prime the dendritic cells with the tumor antigen. And you can take antigens from the tumor tissue itself if you have, or you take specific tumor peptides which you give into the culture, and then the dendritic cells mature and present these antigens. So you take blood from the patient, You isolate the monocytes, you mature the dendritic cells, you load the immature dendritic cells with the specific peptides or tumor tissue, then you complete the maturation, and then you can inject back the dendritic cells into the patient. Now, there are customized peptides, for example, for CMV, EBV, and other virus, and those peptides which are expressed on several different tumors, they are shared epitopes which you can use if you don't have access to tumor tissue. Here you see, this is the intradermal injection of the dendritics. A lot of trials failed because doctors were not trained and they injected the dendritic cells not intradermally but subcutaneously. If you inject subcutaneously, they cannot access the lymph node, and then they cannot program cytotoxic T cells. You have to do it intradermally. If you see a white spot in the skin like this and like orange skin contexture, then you are right. Now, this is just some examples at the end. This was a lady after I don't know how many chemotherapy, English lady having been treated at Anderson and Mayo Clinic. And you see she had a breast cancer, and all this is liver metastasis in the liver from the breast cancer. And she had 4 rounds of dendritic cells, and the tumor was melting away like butter in the sun. It was gone, basically. And you see here, with each dendritic injection, we do 1 injection every month. The CA15-3 tumor marker, which you can use to monitor, comes down and normalizes. Another case, a glioblastoma case from a pregnant woman who had a very early recurrence, and she was treated, and you see how we can downsize the tumor and stabilize the disease. She lived for 2.5 years. And here, an intriguing example of a small cell lung cancer. You see this huge cancer formation in the lung, which totally resolved in combination with low-dose chemotherapy and dendritic cells. So you can use low-dose chemotherapy which synergizes with the dendritics. If you use high dose, then it will kill your immune system and it won't work. And it's hard to convince oncologists to use only 25% of what they would normally give. Anyway, the new development of so-called checkpoint antibodies, what are those, is very helpful in the context of dendritic cell vaccination. If you have dendritic cells, they present the tumor antigen to T cells, then you have an activation of cytotoxic T cells in the lymph node, and then the T cells look for tumor antigen in the periphery. And when they bind with the T cell receptor to the cancer cell, what's normally happening, there's an immune escape, and that is actually performed by the cancer cell, that the cancer cell expresses so-called co-inhibitory molecules, and PD-L1 is a co-inhibitory molecule which binds to PD-1 on the T cell. And if this binding happens, then the apoptotic signal goes not from the T cell into the cancer cell, but vice versa, from the cancer cell into the T cell, and the T cell is killed. So by using antibodies which block this interaction between PD-1 and PD-L1, Keytruda is one of these medications you can use. You block this co-inhibition, and then you have a much more effective activation of the T cells against the cancer cell. So we have done a little trial in pancreatic cancer patients with metastatic disease, and you see in all patients where we combined dendritic cells with the PD-1 antibody, we had these patients have survived more than 2 years. Some of them are now after 4 years. So we have seen a tremendous improvement in outcome and survival by combining dendritic cells with checkpoint antibodies. So I think that was everything. Yeah, I come to my conclusion. I think inflammation is a common denominator for chronic disease. It triggers are dysbiotic microbiota, mitochondrial disorder, virus, AGEs. innate immunity can function as a first target to cause inflammation, and inflammatory M1 macrophages significantly support and sustain ongoing inflammation. Now, what you can do to condition the environment is what we do. We correct the microbiome, very important. First step, we balance the pH in the tissue. We do hormone balancing. We do antioxidant treatment with infusions of curcumin. And we do heavy metal detox, which is very important. I find that most Asians have very high cadmium, aluminium, mercury, and if you don't detox, then that's a permanent stimulus of inflammatory response. And we correct the mitochondrial metabolism, and after having done that, we do the immunotherapy, because then it's much more powerful. I want to show you my last slide. Imagination is more important than knowledge. Okay, please remind that. Thank you very much.
Thank you so much, Prof.
Thank you so much, Professor. May we ask questions? Are there any? Please do approach the microphone.
Good morning, Prof. I would like to ask, what are the techniques you use to test the pH of the urine? Whether there's normal urine FME or there's any special test for the pH?
To test in the urine?
Yeah, for the pH,
well,
for the acidity of the body.
The pH in the urine is easy to test, okay? You have
Is it accurate? Is it the best technique that we should use?
No.
Yeah, can you please?
Because if you drink alkalic water, okay, a lot of people do because they want to get rid of the acidity. You start drinking alkalic water, your urine will be neutralized or getting alkalic within a few hours, because the alkalic water is neutralized in the kidney within 30-45 minutes. But only less than 1% of the alkalic base is incorporated into the tissue. But what we want to do is to normalize the pH in the tissue, not in the urine.
Yes.
So we have an equipment from Switzerland which indirectly, by measuring base excess, can give you a extrapolated information on the pH in the tissue. And that's what we actually do. We measure base excess.
Okay, it's not available here. Okay, another one question. We are introduced with the fat stem cells, which for me, the fat is where the toxins been accumulated. And we want to produce a growth factors or stem cell from the stems from the fat cell. Can you please comment about it?
Sorry. You have to step back. I didn't get your question. It was too fast.
We have been introduced with fat stem cells
Fat
to produce stem cells from the fat.
Yeah.
Whether they want to get the stem cells or growth factors from the fat cells. So where we know that the fat cells is a protective, is a hormones and protective hormones that accumulate toxic.
Yeah.
So what do you comment about this to heal ourselves with a stem cell from the fat cells? Thank you.
Okay, I got it. Fat stem cells, what people claim to have mesenchymal fat-derived stem cells, you must be careful, because if you ask those people who offer this product, you have to ask them how many stem cells are actually inside your product. Because if you aspirate fat, you get a lot of different types of cells, and you get toxins, of course, from the fat. So I'm very cautious to use fat stem cells. That's one reason, because the number of stem cells is very few in those products. However, there are some publications showing that if you purify the CD133 positive stem cells from the fat, then you have quite good results if you condition the tissue properly and so on. But be reminded about one other thing. It's quite a different thing to take stem cells and to procure and expand the stem cells outside the body in an artificial environment. you need enough stem cells to have efficacy in the patient. So some people expand and replicate the fat stem cells outside the body. And it has been published in 2012 in Cancer Research. If you replicate fat stem cells more than 6 times outside the body in an artificial cultural environment, you have a high risk to immortalize some of the fat stem cells. And immortalized cells, if you give them back into the patient, can cause cancer. Now, if you expand 1 million cells or 10 million cells, and there are only 5 or 10 immortalized cells in your product, you will never be able to detect them. So that's a critical point. And use fat stem cells, but do not expand them for too many replications outside the body. That's dangerous.
I have a fairly simple question. My question is, as you were talking about the acidity in the body, yes. I don't know if this is a relevant question, but is baking soda a good enough something that you could use to help with acidity or lowering acidity in the body? And if so, how much on a daily basis would you recommend? I would think that it would depend on the chronic the acidity level of that person. But do you have any recommendations for that?
Well, I don't specifically have used baking soda. What you can do, you can take baking soda and mix it with lemon juice, and then it will form a mixture which can whiten your teeth. So it's quite aggressive, okay? But baking soda as a basic compound, alkali compound, will not be soft enough to really balance your pH in the tissue. It will balance your urine and to some extent your blood, but not the tissue. And that's the critical point. You need to balance inside the tissue.
Okay, thank you.
You're welcome.
Last question, Dr. Fred. In one of your slides, you had shown that you harvest the dendritic cells from autologous source.
Yes.
Could you harvest this from cord blood?
No, unless the cord blood is your own. This is the difference to treating neurodegenerative disease or autoimmune disease. Well, no, in autoimmune disease, it is also critical to use the patient's own monocytes, because the immune response is MHC restricted. That means that immune cells recognize self and non-self. And if you take the monocytes from a different person and show an antigen to the T cells, then they cannot control the autoimmune disease. And the same is true for the dendritic cells. You need to have the dendritic cells procured from the patient's own monocytes. Otherwise, the MHC expressed on the tumor cell is different than the MHC expressed on the dendritic cell, and then it doesn't work.
That means you can't even use a donor.
As a donor, you can use only the patient himself.
You can't use allogenic source.
Not for dendritic cell purposes.
Okay, thank you.
You're welcome.
Professor Fred, what sort of modalities would you use to balance the pH within the tissue cells?
Well, we have this, I showed this yesterday. We have one compound which is called Relief, which is a procaine molecule-based compound. The former procaine, every procaine is on the market for more than 30 years. It's a local anesthetic. And you have it also here, I think. But the normal procaine, which you can use, okay? If you don't have access to what we have, you just use procaine and you add bicarbonate. There's a formula how much bicarbonate with procaine I can give to you. No problem. Oh, by the way, all my slides are from yesterday and today are free. You can have them. I don't mind. You can combine procaine with bicarbonate and infuse that over 5-6 days, and that will balance the pH in the tissue, and you will see what a remarkable effect on its own it has, especially if you can combine with V cells, like you said yesterday. V cells, I have to make this comment from Dr. Edward. We also produce V cells, very small embryonic-like stem cells, which you can easily procure, which you do not have to expand outside the body, and they are very safe and very powerful. And for me, they are the most favorite stem cell in the clinic you can use. But coming back to you, procaine-based bicarbonate infusions, curcumin infusions, that's very helpful to normalize the tissue. The resveratrol and the mitochondrial, for mitochondrial disease, and at the end, if you treat mitochondria properly, you also balance the pH because you lower oxidative stress. And for mitochondria, you need Q10, you need B vitamin complex, very important because the complexes of the electron transport chain are composed of vitamin B. And you need carnitine, extremely important. Carnitine is the only compound which brings in fatty acids through the membrane. Alpha lipoic acid, D-ribose as a building complex for ATP. One substance called PQQ, pyridine quinone, which is the only one which is extremely potent to generate new mitochondria in the cell. And interestingly enough, the highest amount of this compound is in dark chocolate. Eat one piece of dark chocolate a day, you have huge amounts. So these are the things you do.
So these are the things that one can do orally
yes,
rather than
these are the
intravenous.
supplements you can do add to the infusions.
Thank you.
Okay.
Any more questions? Otherwise, can we call on Dr. Homer Lim and Dr. Mazia for the token of appreciation, please?
No need, sorry. Thank you. No need.
Oh, no need. My partner said.
Thank you for that. All right, we shall.
Okay, we just have a 1 slide or 1.5 slide show. I'm supposed to lecture on the benefits of Manuka honey, which we did not have a chance anymore, instead I would just do an MC, so I'll just show 1 slide. And, other benefits of the Manuka honey, we've used it on wounds. This is a breast augmentation wound that did not want to heal. 1 week of application of Manuka honey with virgin coconut oil and olive oil. And then on the 2nd week, you see a good closure and healing state. So, and then at the bottom, we are doing studies for acne and eczema with Dermovision. So it's a clinical study. And I'm here actually to invite some practitioners, if we could put together, collaborate on studies, because we do have good benefits for it. 2nd slide, please. The other uses of the Manuka honey are as follows. And just like the dark chocolate that Professor Fred had mentioned, Manuka honey somehow brings up the pH. So lessens the acidity. That is, I cannot conclude it yet. That's why we're doing the study. That's why perhaps it does help in wound healing. It's also been used for acid reflux and for all those good stuff up there that have been studied. Some clinical, some are hearsay, but just the same, this is a product for as long as it is used properly in pure raw form with a good enough MUF factor or the MGO factor. Those are the benefits that we could actually get. So if you have like 200 grams of it, and you can mix it 1:1:1 proportion with virgin coconut oil and olive oil. You can actually help your patients with eczema and acne, and for some wounds. So those are just an invite. Also, please, if you are interested in doing the studies with us, kindly give us your contact information at the Secretariat so we can email you and we can do clinical studies together and have it published in our forthcoming publication with IAIMS. It will be an international publication. Thank you so much. So now we will be having our morning break. So we'll give you about 10 minutes for your morning break and then come back for the next lecture, please. Thank you so much.